Welcome to Uber School's comprehensive guide to cardiovascular pathology for the USMLE, Step 1. I'm your host, Pete, joined by my esteemed colleague, Crash. We've got a lot of ground to cover today, so let's dive right in.
That's right, Petey boy. We're going to take a deep dive into the heart of the matter, literally. Let's start with atherosclerosis, the root of many cardiovascular evils. What's the deal with this artery clogging menace?
Well, Crash, atherosclerosis is a chronic inflammatory process affecting the arteries. It all starts with endothelial injury, which can be caused by various factors like hypertension, smoking, or high cholesterol levels. This injury allows lipids, especially LDL cholesterol, to accumulate in the arterial wall.
Ah, the old cholesterol sneak attack. And what happens next, oh wise one?
Once those lipids get in, they oxidize and trigger an inflammatory response. Monocytes from the bloodstream enter the arterial wall and differentiate into macrophages. These macrophages then engulf oxidized LDL, becoming foam cells. As this process continues, a fatty streak forms, which is the earliest visible lesion in atherosclerosis.
Foam cells, huh? Sounds like something you'd find in a latte, not an artery. So what turns these fatty streaks into full-blown plaques?
Great question, Crash. As the process progresses, smooth muscle cells migrate from the media to the intima of the artery. They proliferate and produce extracellular matrix components like collagen, which forms a fibrous cap over the growing lipid core. This structure is what we call an atherosclerotic plaque, or atheroma.
All right, time for a quick USMLE style question. You ready, Petey?
Hit me with it, Crash.
A 55-year-old man with a history of hypertension and hyperlipidemia presents with chest pain. Coronary angiography revealed significant stenosis in the left anterior descending artery. Which of the following cells plays a crucial role in the early formation of atherosclerotic lesions? A. Neutrophils. B. Eosinophils. C. Macrophages. D. T. Lymphocytes. E. Mast cells.
Ah, a classic. The correct answer here is C, macrophages. As we just discussed, macrophages play a crucial role in the early stages of atherosclerosis by engulfing oxidized LDL and becoming foam cells. These foam cells are the hallmark of fatty streaks, the earliest visible atherosclerotic lesions.
Spot on, Pete. Now let's talk about the risk factors for atherosclerosis. We've got the usual suspects like hypertension and hyperlipidemia, but what else should our future docs be on the lookout for?
Great point, Crash. We can divide risk factors into modifiable and non-modifiable categories. Non-modifiable factors include age, male sex, and family history. Modifiable risk factors, besides hypertension and hyperlipidemia, include smoking, diabetes mellitus, obesity, and a sedentary lifestyle.
Don't forget about our old friend, the metabolic syndrome. Speaking of which, did you hear about Marcus Cooper? Legend has it, he once diagnosed an entire hospital ward with metabolic syndrome just by looking at their lunch trays.
Crash, I swear, your Marcus Cooper stories get wilder every time. But you're right about metabolic syndrome, it's a significant risk factor. Now, let's move on to the complications of atherosclerosis. What happens when these plaques decide to cause trouble?
Well, Pete, when plaques go rogue, we're in for a world of hurt. The big three complications are plaque rupture, thrombosis, and embolism. Care to break those down for our listeners?
Certainly. Plaque rupture occurs when the fibrous cap of an atherosclerotic plaque breaks open. This exposes the thrombogenic core of the plaque to the bloodstream, leading to rapid thrombus formation. This sudden blockage can cause acute events like myocardial infarction or stroke, depending on the affected artery.
Nasty business, that. And I suppose that leads us nicely into thrombosis?
Exactly. Thrombosis can occur even without plaque rupture. As plaques grow, they narrow the arterial lumen, leading to turbulent blood flow. This turbulence, combined with the dysfunctional endothelium overlying the plaque, can trigger thrombus formation. These thrombi can either occlude the artery at the site of formation or break off and travel downstream, causing an embolism.
All right, time for another USMLE question. You up for it, Petey?
Always, Crash. Let's hear it.
A 60-year-old man with a history of hyperlipidemia suddenly develops severe chest pain and shortness of breath. ECG shows street segment elevation in leads V1-V4. Which of the following is the most likely underlying pathological process? A. Gradual narrowing of the coronary artery. B. Coronary artery spasm. C. plaque rupture and thrombosis D, embolism from a distant source E, myocarditis.
Great question. The correct answer here is C, plaque rupture and thrombosis. The sudden onset of symptoms and the Saint segment elevation on ECG are classic signs of an acute myocardial infarction. In patients with atherosclerosis, the most common cause of acute MI is plaque rupture, followed by rapid thrombus formation, leading to sudden coronary artery occlusion.
Nailed it, Pete. Now, let's shift gears a bit and talk about how we diagnose atherosclerosis. What tools do we have in our diagnostic arsenal?
Well, Crash, diagnosing atherosclerosis often involves a combination of clinical assessment and imaging techniques. For peripheral artery disease, we might start with a simple ankle brachial index, ABI. For coronary artery disease, stress testing can be useful to detect ischemia.
And what about the fancy imaging stuff? I hear the radiologists have some pretty cool toys these days.
Indeed they do. Computed tomography, court angiography, can provide detailed images of the coronary arteries and can even detect calcification in atherosclerotic plaques. Magnetic resonance angiography, MRA, is another non-invasive option that doesn't use ionizing radiation.
But the gold standard is still good old coronary angiography, right?
Correct. Crash. While it's more invasive, coronary angiography provides the most detailed look at the coronary arteries and allows for immediate intervention if necessary. It's particularly useful when planning revascularization procedures like angioplasty or bypass surgery.
Speaking of interventions, let's talk treatment. How do we tackle this artery clogging menace?
Treatment for atherosclerosis is multifaceted. Crash. First and foremost, we need to address those modifiable risk factors we mentioned earlier. This means lifestyle modifications like smoking cessation, regular exercise, and a heart-healthy diet.
Ah, yes, the old eat your veggies and take a walk prescription. But I'm guessing we've got some pharmaceutical big guns too, right?
Absolutely. Statins are the cornerstone of pharmacological therapy for atherosclerosis. They not only lower LDL cholesterol, but also have pleiotropic effects that help stabilize plaques. For patients with hypertension, we might use ACE inhibitors or ARBs, which have been shown to have beneficial effects beyond just lowering blood pressure.
And what about antiplatelet agents? I hear aspirin is still going strong after all these years.
You're right, Crash. Low-dose aspirin is often recommended for primary prevention in high-risk individuals and for secondary prevention in those with established cardiovascular disease. For higher-risk patients or those who've had acute coronary syndromes, we might use more potent antiplatelet agents like clopidogrel or ticagrelor.
All right, time for another USMLE question. You ready, Pete?
Fire away, Crash.
A 50-year-old man with a history of hyperlipidemia is started on atorvastatin. Which of the following is the primary mechanism by which statins reduce cardiovascular risk? A. Inhibition of HMG-CoA reductase. B. Activation of lipoprotein, lipase C. Inhibition of cholesterol absorption in the intestine D. Increased bile acid excretion E. Activation of LDL receptors.
Excellent question. The correct answer is A. Inhibition of HMG-CoA reductase. Statins work by inhibiting HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis. This leads to decreased cholesterol production in the liver and upregulation of LDL receptors, resulting in increased LDL clearance from the bloodstream.
Spot on, Pete. Now let's move on to coronary artery disease. How does atherosclerosis lead to this common killer?
Great transition, Crash. Coronary artery disease, CAD, is essentially atherosclerosis of the coronary arteries. As plaques build up in these crucial vessels, they can restrict blood flow to the heart muscle, leading to ischemia. This can manifest as stable angina, where symptoms occur predictably with exertion.
And I'm guessing when things go south, we're talking about acute coronary syndrome, right?
Exactly, Crash. Acute coronary syndrome, ACS, occurs when there's a sudden reduction in coronary blood flow, usually due to plaque rupture and thrombosis. This can lead to unstable angina, non-street elevation myocardial infarction in STEMI, or Saint elevation myocardial infarction, STEMI, depending on the severity and duration of ischemia.
All right, let's break those down a bit. What's the difference between stable angina and unstable angina?
Good question. Stable angina is characterized by predictable chest pain that occurs with exertion and is relieved by rest or nitroglycerin. It's caused by a fixed narrowing of the coronary arteries that limits blood flow during increased demand. Unstable angina, on the other hand, is more serious. The pain occurs at rest or with minimal exertion, lasts longer, and may not be fully relieved by nitroglycerin. It's often caused by a ruptured plaque or partially occlusive thrombus.
And how about NSTEMI versus STEMI? They sound pretty similar to me.
While they're both types of myocardial infarction, there are important differences. In NSTEMI, there's partial or intermittent blockage of a coronary artery, leading to some damage to the heart muscle. The ECG typically shows street segment depression or T-wave inversion, but no street segment elevation. STEMI, on the other hand, involves complete blockage of a coronary artery, causing more extensive damage. It's characterized by saint segment elevation on the ECG.
Gotcha. So how do we diagnose these conditions? I'm guessing ECG plays a big role.
You're absolutely right, Crash. ECG is crucial in the initial evaluation of suspected ACS. As we mentioned, ST segment elevation is the hallmark of STEMI. For NSTEMI and unstable angina, we might see street segment depression, T-wave inversion, or even a normal ECG. But ECG alone isn't enough. We also rely heavily on cardiac biomarkers, particularly troponin.
Ah, yes, troponin, the heart's distress signal. How does that work exactly?
Troponin is a protein found in cardiac muscle cells. When these cells are damaged, as in a myocardial infarction, troponin is released into the bloodstream. Elevated troponin levels are highly sensitive and specific for myocardial injury. In ACS, we typically see a rise and fall in troponin levels over time.
Interesting stuff, Pete. Now, let's hit our listeners with another USMLE style question. You ready?
Always ready, Crash. Let's hear it.
A 65-year-old man presents to the emergency department with chest pain that began 2 hours ago. His ECG shows street segment elevation in leads 2, 3, and AVF. Which of the following is the most likely diagnosis? A. Anterior wall, MIB, inferior wall, MIC, lateral wall, MID, septal, MIE, right ventricular, MI.
Great question, Crash. The correct answer is B. Inferior wall MIST segment elevation in leads 2, 3, and AVF is characteristic of an inferior wall myocardial infarction, which typically involves the right coronary artery. It's important to remember the ECG leads and their corresponding areas of the heart for the USMLE exam.
Nailed it, Pete. Now let's talk treatment. When someone comes in with an acute MI, what's our game plan?
The key in acute MI treatment is rapid reperfusion, Crash. For STEMI, we have two main options: primary percutaneous coronary intervention, PCI, or fibrinolytic therapy. PCI, which involves coronary angiography and often stent placement, is the preferred method if it can be performed in a timely manner.
And if PCI isn't available?
Then we turn to fibrinolytic therapy, drugs that break down the clot occluding the coronary artery. These include agents like alteplase or tenecteplase. However, fibrinolytics have more contraindications and a higher risk of bleeding compared to PCI.
What about for NSTEMI and unstable angina?
For NSTEMI and high-risk unstable angina, we typically use an early invasive strategy with coronary angiography and revascularization if appropriate. For lower-risk cases, we might opt for an initial conservative strategy with medical management, reserving invasive procedures for those who don't respond to medication.
And I'm guessing there's a bunch of medications involved too, right?
Absolutely, Crash. In the acute setting, we use antiplatelet agents like aspirin and often AP2Y12 inhibitor like clopidogrel. Anticoagulants such as heparin are also typically used. Beta blockers, ACE inhibitors, and statins are usually started early as well, assuming there are no contraindications.
Sounds like a pharmaceutical cocktail. Now let's switch gears a bit and talk about some of the complications of MI. What kind of aftermath are we looking at?
Great question, Crash. Complications of MI can be divided into early and late complications. Early complications occurring within the first week or so include arrhythmias, cardiogenic shock, and mechanical complications like ventricular free wall rupture, ventricular septal rupture, and acute mitral regurgitation due to papillary muscle rupture.
Yikes, that sounds serious. What about the late complications?
Late complications occurring weeks to months after the MI include heart failure, ventricular aneurysm formation, and even the dreaded Dressler syndrome, which is a form of pericarditis that can occur weeks to months after an MI.
Speaking of heart failure, that seems like a natural segue. Want to dive into that topic next?
Absolutely, Crash. Heart failure is a major consequence of coronary artery disease and other cardiovascular conditions. It's defined as the inability of the heart to pump blood effectively to meet the body's metabolic demands. Heart failure can be classified as systolic, reduced ejection fraction, or diastolic, preserved ejection fraction.
And what causes this pump failure?
The causes are numerous. Crash, coronary artery disease, and previous myocardial infarction are major causes, leading to systolic heart failure. Hypertension can cause both systolic and diastolic heart failure. Other causes include valvular heart disease, cardiomyopathies, and even some systemic conditions like thyroid disorders.
All right, time for another USMLE question. You ready, Pete?
Hit me with it, Crash.
A 70-year-old woman presents with dyspnea on exertion, orthopnea, and peripheral edema. Her echocardiogram shows an ejection fraction of 60% and left ventricular hypertrophy. Which of the following is the most likely diagnosis? A. Systolic heart failure. B. Diastolic heart failure. C. Constrictive pericarditis. D. Restrictive cardiomyopathy. E. Acute mitral regurgitation.
Excellent question, Crash. The correct answer here is B. Diastolic heart failure. The patient's symptoms are consistent with heart failure, but her preserved ejection fraction, 60%, indicates that systolic function is normal. The presence of left ventricular hypertrophy suggests diastolic dysfunction, where the ventricle has trouble relaxing and filling properly.
Nailed it, Pete. Now let's talk about how we diagnose and treat heart failure. What tools do we have in our arsenal?
Diagnosis of heart failure typically involves a combination of clinical assessment, laboratory tests, and imaging studies. Clinically, we look for signs and symptoms like dyspnea, fatigue, peripheral edema, and jugular venous distension. Lab tests might include BNP or NT-proBNP, which are elevated in heart failure.
And what about imaging? I hear echocardiography is pretty important.
You're absolutely right, Crash. Echocardiography is crucial in the evaluation of heart failure. It allows us to assess cardiac structure and function, including ejection fraction, chamber sizes, wall thickness, and valve function. It's particularly useful in distinguishing between systolic and diastolic heart failure.
Got it. And how do we treat these folks once we've made the diagnosis?
Treatment of heart failure is multifaceted. Crash. For systolic heart failure, we typically use a combination of ACE inhibitors or ARBs, beta blockers, and mineralocorticoid receptor antagonists. These medications have been shown to improve survival in systolic heart failure. We might also use diuretics to manage fluid overload symptoms.
And what about diastolic heart failure? Same approach?
Treatment for diastolic heart failure is a bit trickier, Crash. While we use many of the same medications, they haven't shown the same mortality benefit as in systolic heart failure. The focus is often on controlling blood pressure, managing fluid status with diuretics, and treating underlying causes like coronary artery disease or hypertension.
Interesting stuff, Pete. You know, all this talk about heart failure reminds me of another Marcus Cooper story. Did you hear about the time he diagnosed heart failure in a patient just by listening to their footsteps?
Crash, I swear your Marcus Cooper stories get more outlandish every time. But speaking of listening, let's talk about heart sounds and murmurs. They're crucial for diagnosing various cardiovascular conditions, including valvular heart diseases.
Ah, music to my ears, or should I say murmurs to my stethoscope. What's the deal with these heart noises?
Well, Crash, normal heart sounds minus S1 and S2 are produced by closure of the atrioventricular and semilunar valves, respectively. Murmurs, on the other hand, are abnormal heart sounds caused by turbulent blood flow. They can be indicative of various valvular abnormalities or other cardiac conditions.
And how do we characterize these murmurs?
We describe murmurs based on several characteristics: timing, systolic versus diastolic, location, intensity, graded on a scale of 1 to 6, quality, e.g., harsh, blowing, musical, and radiation. The combination of these features often points to specific valvular abnormalities.
All right, time for another USMLE question. You up for it, Pete?
Always, Crash. Let's hear it.
A 65-year-old man presents with exertional dyspnea and a harsh crescendo-decrescendo systolic murmur heard best at the right upper sternal border. The murmur increases with hand grip and decreases with standing. Which of the following is the most likely diagnosis? A. Mitral regurgitation. B. Aortic stenosis. C. Mitral stenosis. D. Aortic regurgitation. E. Hypertrophic cardiomyopathy.
Excellent question, Crash. The correct answer here is B, aortic stenosis. The harsh crescendo-decrescendo systolic murmur heard best at the right upper sternal border is classic for aortic stenosis. The murmur characteristics increasing with hand grip, which increases afterload, and decreasing with standing, which decreases venous return, are also consistent with aortic stenosis.
Nailed it, Pete. Now let's dive deeper into valvular heart diseases. What are the main culprits we need to know about?
Great question, Crash. The four main valvular diseases we need to focus on are aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. Each of these has distinct causes, pathophysiology, and clinical presentations.
All right, let's start with aortic stenosis. What's the deal with this narrowed valve?
Aortic stenosis is characterized by narrowing of the aortic valve opening, which obstructs blood flow from the left ventricle to the aorta. In developed countries, the most common cause in adults is age-related calcific degeneration. Other causes include congenital bicuspid aortic valve and rheumatic heart disease.
And what kind of symptoms are we looking at?
The classic triad of symptoms in aortic stenosis is angina, syncope, and heart failure. These typically occur late in the disease course. Patients may also experience exertional dyspnea and fatigue. On examination, we hear that harsh systolic murmur we just discussed, often accompanied by a soft or absent S2.
Gotcha. And how about aortic regurgitation? What's different there?
Aortic regurgitation involves backflow of blood from the aorta into the left ventricle during diastole. It can be acute, caused by things like infective endocarditis or aortic dissection, or chronic, often due to connective tissue disorders or rheumatic heart disease. The key feature here is a diastolic decrescendo murmur heard best at the left sternal border.
Interesting. Now let's move to the mitral valve. What's the scoop on mitral stenosis?
Mitral stenosis is narrowing of the mitral valve opening, which obstructs blood flow from the left atrium to the left ventricle. The most common cause worldwide is rheumatic heart disease, though we're seeing less of that in developed countries. Patients typically present with dyspnea, fatigue, and signs of right heart failure due to pulmonary hypertension.
And the murmur for this one?
The classic murmur of mitral stenosis is a diastolic rumble heard best at the apex with the patient in the left lateral decubitus position. We also often hear an opening snack after S2, followed by this rumble.
All right, last but not least, mitral regurgitation. What's the deal there?
Mitral regurgitation involves backflow of blood from the left ventricle into the left atrium during systole. It can be acute, often due to things like papillary muscle rupture in MI, or chronic, caused by various conditions including mitral valve prolapse, rheumatic heart disease, or left ventricular dilation. The murmur is typically a holosystolic murmur heard best at the apex, radiating to the axilla.
Wow, that's a lot to keep straight. How do we go about treating these valvular conditions?
Treatment depends on the specific valve disease and its severity, Crash. For mild cases, we often start with medical management, things like diuretics for symptom control, ACE inhibitors for afterload reduction in regurgitant lesions, and anticoagulation in patients with atrial fibrillation. However, definitive treatment for severe valvular disease is usually surgical, either valve repair or replacement.
And I hear there are some fancy new minimally invasive procedures these days, right?
You're absolutely right, Crash. Transcatheter procedures have revolutionized the treatment of certain valve diseases, especially in high-risk surgical candidates. The most well-established is transcatheter aortic valve replacement, TAVR, for aortic stenosis, but we're seeing similar approaches being developed for other valve diseases as well.
Fascinating stuff, Pete. You know, all this talk about heart valves reminds me of another Marcus Cooper story. Did you hear about the time he repaired a mitral valve using only a paperclip and a stick of gum?
Crash, I swear your Marcus Cooper stories are getting more outlandish by the minute. But speaking of outlandish, let's talk about some of the rarer cardiovascular conditions our USMLE students might encounter. How about we dive into cardiomyopathies?
Sounds like a plan, Pete. What exactly are cardiomyopathies?
Cardiomyopathies are a group of diseases that primarily affect the heart muscle. They can be classified into several types, but the main ones we need to focus on for the USMLE are dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy.
Hardy. Each of these has distinct pathophysiology, clinical presentations, and management strategies.
All right, let's start with dilated cardiomyopathy. What's the deal with this stretched out heart? Dilated cardiomyopathy, DCM, is characterized by enlargement of the heart chambers, particularly the left ventricle, leading to impaired systolic function. It's the most common form of cardiomyopathy. Causes are varied and include ischemic heart disease, genetic factors, alcohol abuse, certain medications like doxorubicin, and viral infections.
And what kind of symptoms do these patients typically present with?
Patients with DCM often present with signs and symptoms of heart failure minus dyspnea, fatigue, peripheral edema. They may also experience arrhythmias and are at increased risk for thromboembolic events due to blood stasis in the dilated chambers. On examination, you might hear an S3 gallop and systolic murmurs of mitral or tricuspid regurgitation due to annular dilation.
Gotcha. And how do we diagnose and treat these folks?
Diagnosis typically involves echocardiography, which shows the dilated chambers and reduced ejection fraction. We might also use cardiac MRI for better tissue characterization. Treatment is generally similar to that of systolic heart failure, minus ACE inhibitors or ARBs, beta blockers, and aldosterone antagonists form the cornerstone. We also manage symptoms with diuretics and treat any underlying causes if identified.
All right, now let's move on to hypertrophic cardiomyopathy. This is the one with the thick heart walls, right?
Exactly, crash. Hypertrophic cardiomyopathy, HCM, is characterized by unexplained left ventricular hypertrophy, often with asymmetric septal hypertrophy. It's typically caused by genetic mutations in sarcomere proteins. The hypertrophy can lead to left ventricular outflow tract obstruction, diastolic dysfunction, and increased risk of arrhythmias.
And what about symptoms? I hear this is a sneaky one.
You're right, Crash. HCM can be insidious. Some patients are asymptomatic and diagnosed incidentally, while others may present with exertional dyspnea, chest pain, palpitations, or syncope. Tragically, sudden cardiac death can be the first manifestation, particularly in young athletes. On examination, you might hear a systolic murmur that increases with maneuvers that decrease preload, like standing or Valsalva.
Yikes, that's scary stuff. How do we manage these patients?
Management of HCM is aimed at symptom relief and prevention of sudden cardiac death. Beta blockers or non-dihydropyridine calcium channel blockers are first line for symptom control. In patients with obstruction, we avoid agents that decrease preload or afterload. For high-risk patients, implantable cardioverter defibrillators are recommended for primary prevention of sudden cardiac death. In severe cases, surgical myectomy or alcohol septal ablation might be considered.
Fascinating. Now, last but not least, restrictive cardiomyopathy. What's the story there?
Restrictive cardiomyopathy is the least common of the three, crash. It's characterized by normal or decreased volume of both ventricles, biatrial enlargement, and impaired ventricular filling with preserved systolic function. Causes include infiltrative diseases like amyloidosis, sarcoidosis, or hemochromatosis, as well as endomyocardial fibrosis and radiation-induced fibrosis.
And how do these patients typically present?
Patients with restrictive cardiomyopathy often present with signs and symptoms of right heart failure, peripheral edema, hepatomegaly, ascites. They may also experience dyspnea and fatigue. A key feature is the presence of prominent X and Y descents in the jugular venous pulse, often described as AW pattern. Diagnosis is typically made by echocardiography showing normal or small ventricles with preserved systolic function but impaired diastolic filling.
Sounds tricky to manage. What's our approach here?
You're right, Crash. It can be challenging. Management is often focused on treating the underlying cause if possible, such as chelation therapy for hemochromatosis. Symptom management with diuretics can help, but we need to be careful as these patients are very sensitive to changes in preload. Some patients may ultimately require cardiac transplantation.
All right, time for another USMLE question. You ready, Pete?
Always ready, Crash. Hit me with it.
A 25-year-old male athlete collapses during a basketball game. He is found to be in ventricular fibrillation and is successfully resuscitated. Subsequent echocardiography shows asymmetric septal hypertrophy. Which of the following is the most appropriate next step in management? A. Beta blocker therapy. B. Implantable cardioverter defibrillator. C. Surgical myostomy. D. Anticoagulation. E. Radiofrequency ablation.
Excellent question, Crash. The correct answer here is B. Implantable cardioverter defibrillator, ICD. This patient has suffered a cardiac arrest likely due to hypertrophic cardiomyopathy, HCM, as evidenced by the asymmetric septal hypertrophy on echo. In patients with HCM who have survived a cardiac arrest, an ICD is indicated for secondary prevention of sudden cardiac death. While beta blockers are often used for symptom control in HCM, they wouldn't be sufficient for a patient who has already suffered a cardiac arrest.
Nailed it, Pete. Now let's switch gears a bit and talk about some of the congenital heart defects. These are always tricky on the USMLE.
Absolutely, Crash. Congenital heart defects are a crucial topic for the USMLE. They can be broadly categorized into cyanotic and acyanotic defects based on whether they typically cause cyanosis at birth. Let's start with some of the acyanotic defects, things like atrial septal defect, ASD, ventricular septal defect, VSD, and patent ductus arteriosus, PDA.
All right, let's break those down. What's the deal with atrial septal defects?
Atrial septal defects are openings in the septum between the atria, allowing blood to flow between the left and right atria. The most common type is the secundum ASD. These defects create a left-to-right shunt, which can lead to right heart volume overload over time. Patients are often asymptomatic in childhood, but may develop symptoms like dyspnea and fatigue in adulthood.
And how do we diagnose and treat these?
Diagnosis is typically made by echocardiography, which can show the defect and the right heart dilation. On auscultation, you might hear a fixed split S2 due to the constant volume load on the right side. Treatment depends on the size of the defect and the patient's age. Small defects may close spontaneously, while larger ones often require closure either surgically or via catheter-based techniques.
Got it. Now, how about ventricular septal defects? Are they similar?
Ventricular septal defects are similar in that they also create a left-to-right shunt, but they occur in the ventricular septum. The key difference is that VSDs subject the pulmonary circulation to high pressure as well as high flow, which can lead to pulmonary hypertension over time if left untreated. The classic finding on exam is a harsh holosystolic murmur heard best at the left lower sternal border.
And treatment for these?
Treatment for VSDs depends on the size of the defect and the presence of symptoms. Small VSDs, often called restrictive VSDs, may close spontaneously and can be monitored. Larger defects typically require surgical closure to prevent complications like pulmonary hypertension and heart failure.
All right, last but not least in our acyanotic trio, patent ductus arteriosus. What's the story there?
Patent ductus arteriosus occurs when the ductus arteriosus, a normal fetal connection between the aorta and pulmonary artery, fails to close after birth. This creates a left-to-right shunt from the aorta to the pulmonary artery. The classic finding is a continuous machinery murmur heard best in the left infraclavicular area. Like other left-to-right shunts, it can lead to pulmonary hypertension if left untreated.
And how do we manage these little ones?
In premature infants, we might try medical closure with indomethacin or ibuprofen. For older infants and children, closure is typically achieved either surgically or via catheter-based techniques. It's important to close significant PDAs to prevent complications like pulmonary hypertension and heart failure.
Fascinating stuff, Pete. You know, all this talk about holes in the heart reminds me of another Marcus Cooper story. Did you hear about the time he repaired an ASD using only a Band-Aid and a paperclip?
Crash. I swear your Marcus Cooper stories are getting more outlandish by the minute. But speaking of outlandish, let's move on to some of the cyanotic congenital heart defects. These are often more complex and can be real stumpers on the USMLE.
All right, hit me with it, Pete. What cyanotic defects do our USMLE students need to know?
The key cyanotic defects to remember are tetralogy of Fallot, transposition of the great arteries, truncus arteriosus, and total anomalous pulmonary venous return. Let's start with the most common one, tetralogy of Fallot.
Ah, yes, the famous TET spell. What's the deal with this four-part defect?
Tetralogy of Fallot consists of four key components: ventricular septal defect, overriding aorta, right ventricular outflow tract obstruction, pulmonary stenosis, and right ventricular hypertrophy. The pulmonary stenosis is the critical lesion here, as it limits blood flow to the lungs and causes right-to-left shunting through the VSD, leading to cyanosis.
And what about these TET spells I've heard about?
TET spells, or hypercyanotic episodes, occur when there's a sudden increase in right-to-left shunting. This can be triggered by anything that decreases systemic vascular resistance or increases pulmonary vascular resistance. Clinically, you see acute worsening of cyanosis, shortness of breath, and irritability. These spells can be life-threatening and require immediate management.
Sounds scary. How do we treat these kids?
Treatment of tetralogy of Fallot typically involves surgical repair in infancy. This includes closing the VSD and relieving the right ventricular outflow tract obstruction. For TET spells, acute management involves placing the child in a knee-chest position to increase systemic vascular resistance, giving oxygen, and sometimes using medications like propranolol or phenylephrine.
Got it. Now, how about transposition of the great arteries? That sounds like a plumbing nightmare.
You're not wrong, Crash. In transposition of the great arteries, TGA, the aorta arises from the right ventricle and the pulmonary artery from the left ventricle. This creates two separate circuits. Deoxygenated blood recirculates to the body, and oxygenated blood recirculates to the lungs. It's incompatible with life unless there's some mixing of blood, usually through a PDA, ASD, or VSD.
Yikes, how do these babies present?
Babies with TGA typically present with severe cyanosis shortly after birth. It's a surgical emergency. Initial management often involves prostaglandin E1 to keep the ductus arteriosus open and balloon atrial septostomy to create an ASD if needed. Definitive treatment is surgical correction, usually with an arterial switch procedure.
All right, time for another USMLE question. You ready, Pete?
Always ready, Crash. Let's hear it.
A newborn presents with cyanosis and tachypnea shortly after birth. Chest X-ray shows a boot-shaped heart. Echocardiography reveals a large ventricular septal defect, an overriding aorta, and right ventricular hypertrophy. Which of the following additional findings would you expect? A. Coarctation of the aorta. B. Pulmonary stenosis. C. Atrial septal defect. D. Patent ductus arteriosus. E. Transposition of the great arteries.
Excellent question, Crash. The correct answer here is B. Pulmonary stenosis. This patient's presentation and echocardiography findings are classic for tetralogy of Fallot. The four components of tetralogy of Fallot are ventricular septal defect, overriding aorta, right ventricular outflow tract obstruction, pulmonary stenosis, and right ventricular hypertrophy. The boot-shaped heart on chest X-ray is also characteristic of tetralogy of Fallot, caused by right ventricular hypertrophy and a concave pulmonary artery segment.
Nailed it, Pete. Now, we've covered a lot of ground today. Any final thoughts for our USMLE students on cardiovascular pathology?
Absolutely, Crash. Cardiovascular pathology is a vast and complex topic, but understanding the basic principles can help you tackle even the toughest USMLE questions. Remember to think about the underlying pathophysiology. How does the disease process affect cardiac structure and function? Always consider how a condition will present clinically and what diagnostic tests will be most useful. And don't forget about management. Knowing the standard treatments for common cardiovascular conditions is crucial.
Great advice, Pete. And remember, folks, if all else fails, you can always try to channel your inner Marcus Cooper and repair that VSD with a paperclip and a stick of gum.
Crash, I think it's time we end this podcast before your Marcus Cooper stories get any more out of hand. To our listeners, thank you for joining us for this Uber School production on cardiovascular pathology. We hope this helps in your USMLE Step 1 preparation. Remember, in the words of William Osler, the good physician treats the disease, the great physician treats the patient who has the disease. Good luck with your studies.
And that's a wrap, folks. This has been Crash.
And Pete, signing off from Uber School. Until next time, keep those hearts pumping and those books open.